Hi again, everybody. This is Dr. David Osser, and I am presenting the algorithm for the psychopharmacology of psychotic depression or major depression with psychotic features. We are on video 8, and in this video, we're going to discuss lithium augmentation of combination therapy, of combination with an antipsychotic and antidepressant for psychotic depression. The previous videos have taken you through the evidence on the various possible combinations, which antidepressant to choose, which antipsychotic to choose, and which to choose second, depending on what you chose first. But if you've had 2 trials and you've had an unsatisfactory response and you're not doing ECT, which we strongly suggest, and you want to keep with pharmacotherapy, we're at node 5. Have you tried adding lithium? So what evidence do we have on that? Well, not a whole lot. There was a case series of 20 patients that was published in 1986. These were people who were on a tricyclic plus a first-generation antipsychotic and had not done well, and they were augmented with lithium. 40% had at least a partial, ranging from a partial to a marked response. So we're not talking about a robust additional response, but a significant number did proceed to further improvement with addition of lithium. Beyond that, we just have some more case series. Here's one also old, this one from 1983. 6 unresponsive patients to a tricyclic plus antipsychotic got lithium. 3 had a dramatic response, so that would be half of them, and 2 more responded gradually. And then there is a small Rothschild series from 1993. These were people that he was treating then with fluoxetine plus perfenazine. He was using an SSRI and a first-generation antipsychotic. There were 8 left in his trial that didn't respond. 3 of them responded to lithium. So that's also in the 40% area. Then in 2009, Birkenhager, to his big study with venlafaxine, imipramine, and venlafaxine, quetiapine, added open-label lithium for 4 weeks to 15 non-responding patients. Remember that? I talked about that a few sessions ago. So they were finished with that study of those 3 possible treatments. He kept them on their blinded initial medications and started lithium. And he adjusted to bring their levels from 0.6 to 1. 9 patients, 60%, had a sustained remission. Remission, not improvement. Now, 5 of the 15 were on combination therapy, because 2 of those groups were monotherapy, and 5 of the 15 were combination. Unfortunately, Dr. Birkenhager did not specify separately whether it was the combination people that responded, these 5 combination people, did they respond to the lithium, or was it the monotherapy people that responded? We can't know that from their published data. Still, they had a pretty decent result from adding lithium. Makes you wonder if you could add lithium to monotherapy to get some improvers. So in short, from this really minimal evidence, we think it's reasonable to add lithium after at least 1 or probably 2 combination therapies of the ones that we've suggested, and if ECT is not a serious consideration. And you might as well use typical blood levels of lithium, and you might as well continue for longer than 4 weeks and maintain them on it if you do get a good response. Because we don't have much else in terms of evidence on augmentation strategies. Maybe after a year you could consider tapering it and see what happens. But if you were fortunate enough to get this long-sought improvement, might as well keep everything going that you were initiating. So in conclusion about lithium augmentation, if the patient has had a couple of antipsychotic plus antidepressant trials and still has not responded satisfactorily, and ECT is not an option, consider augmentation with lithium. The data are very limited, but it seems you can use regular levels, that is to say over 0.6 milliequivalents per liter at trough. If it was effective, you probably want to continue it, since this has been a difficult case of psychotic depression